Next topic is pulmonary AV fistula. So the pulmonary AV fistula, most of the cases is an isolated finding. Sometimes it may be associated with left isomerism or atrial septal defect. But as a whole, hereditary hemorrhagic telangiectasia, also called as Osler-Weber-Rendu syndrome, can be associated with pulmonary AV fistulas. So either single or multiple. So all cases of HHT should be screened for presence of pulmonary AV fistula. So this AV fistula is like any right to left shunt because the pulmonary arterial blood is directly fed to the pulmonary vein while bypassing the capillary plexus. So this is a right to left shunt but at the level of the lungs. So it results in cyanosis with the normal heart. The definition of pulmonary AV fistula, it is a rare anomaly. There can be a direct single or multiple vascular communication between a branch of pulmonary artery and the pulmonary vein. So this bypasses the capillary plexus, which is the usual filter for thrombus and bacteria. So this filter is being bypassed, resulting in systemic exposure to thrombus, resulting in paradoxical thrombosis from a right-sided, for example, a DVT, deep vein thrombosis, giving paradoxical embolism to the systemic circulation and also exposing the systemic circulation to bacteria. So this can result in stroke or brain abscess. So this stroke is called a cryptogenic stroke where the source is not known but it is an embolism. So pulmonary AV fistula can give rise to a cryptogenic stroke because of the paradoxical embolism. Otherwise it is a right to left shunt resulting in hypoxemia. Despite oxygen, this PaO2 cannot be corrected, which in long-standing cases give rise to cyanosis, clubbing, polycythemia because of a right to left shunt but away from the heart. It is cyanosis with a normal heart. So this is the pulmonary AV fistula. This is the pulmonary arterial blood, normal pulmonary arterioles which should have gone through the capillary plexus to the pulmonary veins. So they are taking a different tortuous multiple complex route. So they are either focal or multiple, that is diffuse. So here it can be a focal lung nodule-like lesion but which give rise to a cyanosis if this tract is larger, giving rise to a deoxygenated blood more than 50 grams. Giving rise to deoxygenated blood more than 50 grams by now. So this can include either single, here this is a multiple vascular tract, or it can be tufts of small vessels similar to capillaries. The other names used for pulmonary artery fistula are pulmonary AV malformation, AV aneurysms. If they are hugely dilated, these aneurysms are prone to rupture. So these ruptured pulmonary aneurysms can give rise to hemoptysis or intrapleural rupture resulting in hemothorax, or chronic small ruptures can result in chronic pulmonary hemosiderosis. This is particularly common in patients with mitral stenosis, pulmonary angiomatosis or hematomas. Earlier these lesions were resected thinking they were pulmonary hemangiomas, and after resection of these focal hemangiomas there was improvement in cyanosis, clubbing and polycythemia. So that means they are all pulmonary AV fistulas which are completely correctable, resulting in disappearance of cyanosis. So mostly these are isolated lesions. Sometimes they might be associated with ASD or left isomerism, but the common association is the hereditary hemorrhagic telangiectasia, also called as Osler-Weber-Rendu syndrome. So 70% of all pulmonary AV fistulas are associated with HHT, while 50% of HHT have pulmonary AV fistulas. So all patients with HHT should be screened with a CT either with 3D or by HRCT for presence of pulmonary AV fistula. This can be a source of major bleeding because of rupture of the fistula's aneurysmal tract into the pleura or into the lungs, resulting in